variations in the management of rheumatic diseases related to disparities, essentially, and multiple factors in Delaware community. There's not much data on, if any, actually, no data in Delaware in rheumatology, especially in terms of disparities in access to care, especially given our very diverse population with very different needs across the state. So this was a first attempt to see whether disparities even exist and to further get more insight. This is a slide from the first one. Initially, the push came from the American College of Rheumatology that had projected in their workforce studies how they would be an increased demand with an aging population with a decreasing in supply from the rheumatologists who are aging and retiring and not enough of a training input coming in. So this was projected 10 years ago to 2030 that there would be a greater gap between supply and demand and therefore would increase the limitations in access and further amplify disparities that already exist. This is an update from a different study 5 years later, looking at the trend that occurred, and it appeared that it wasn't exactly as predicted, where there are a number of physicians in rheumatology increased by 20% from 2009 to 2020. And more importantly, the mid-levels actually came into play. And you can see in 2015, 2016, right after the first study was done, there was a greater increase in nurse practitioners and physician assistants taking on the subspecialty roles. So that's in contrast to a bigger picture, which is our focus in here is inflammatory arthritis, and rheumatoid arthritis has an increasing trend, in part because the incidence rates tend to be sort of bimodal, where you have a peak in 20s and 30s, and we have a second peak in 60 to 70s. And we can see that both male and female combined by 2050, there's a continuously increasing number of cases that may still outpace the growth in the field as is happening. And rheumatoid arthritis, for those who are not aware, rheumatoid is the inflammatory type, versus osteoarthritis is the non-inflammatory type. The difference stemming from how the arthritis, which manifests itself in different ways, systemically as well, but most often initially presenting with joint swelling, stiffness, and limited range of motion. I'm showing here one of the criteria for diagnosing rheumatoid arthritis. And the two highlighting points here is one, the high positive antibodies. And these are two commonly tested antibodies that are readily available to basically any provider, and they're done in almost all labs. And if those two are both positive, they're highly specific for rheumatoid arthritis. And the second part of the criteria is the number of joint swelling. So if you have anywhere from 1 to more than 10 joints, and it's been going on for more than 6 weeks, that basically confirms a diagnosis. So when you have patients who are basically relatively easy to be diagnosed, you would imagine that there wouldn't be a delay in diagnosis and treatment. However, there is. And this is just sort of going over a very specific subset. And because sometimes you can have what's called seropositive or seronegative, meaning you don't have to have a positive blood test to be diagnosed. If your symptoms are more than 6 weeks, which gives you 1 point, and you have more than 10 joints that are swollen, small or large, that already gives you 6 points, which is all you need for the diagnosis. So you don't really need to have inflammatory markers or blood tests at all. So diagnosis of rheumatoid arthritis, contrary to popular opinion, doesn't actually require labs. However, if you do have them, it reduces the burden on those who may not be familiar to at least be comfortable with the diagnosis. So as far as the labs that are commonly done, there's two. There's a rheumatoid factor and the anti-CCP. And these two blood tests are always sort of the standard. They've been there for decades. And we can see the likelihood increases greater exponentially, basically, when they're both positive. So 43 compared to 1. And we can put this in a table which highlights how specific and sensitive they both are when done together if they're both positive. The likelihood ratio when you have both rheumatoid factor and CCP is 43. So this is helpful because when you're looking at the treatment options, so this is it's an old, but this was a best representation as a whole. This is from 2014, but we're looking at the prices of the common first-line treatments of rheumatoid arthritis. And down at the bottom left, we can see the 4 initial disease-modifying anti-rheumatic drugs. So that's where these DMARDs are as a whole. And these ones still to this day remain the first line, if you will. These are all oral medications. Anyone diagnosed with rheumatoid arthritis when it's active invariably will go through one of these before they go up to the injectable biologics. I've highlighted on the left the price. So that notice the graph, the axis. So in here, the y-axis shows the price of 22, 33, 48. That's sort of the price you can expect for the oral options. But notice the biologic, these are sort of the injectables, the infusions, some oral as well. And notice they're all in the thousands, anywhere from 2,800 to 5,300. That was in 2014. So looking at, this is from relatively more recent, we're looking at the 10 most expensive drugs, brand drugs, according to GoRx, in the US. And of those, notice the top four, these are all used for inflammatory arthritis. Right? So rheumatoid arthritis is a significant cost burden. At the same time, you wonder how many of patients are actually getting the drugs. And one, is there even a role? Should we even do them? So this is a study that was looking at methotrexate specifically in combination with other medications. And in here, basically, we can look at the last column and we can see the probability of treatment if it's superior to the oral methotrexate. And we can see that the combination therapy often is better combined when methotrexate alone. So we can go back to this column and we can see that methotrexate has been around for a very long time, 1988, and initially used for cancer treatment, and through oncology, it's been used for a lot of autoimmune diseases. To this day, it sort of is your first line. In fact, if I was to say even some countries in the world only have methotrexate, and that's it. That's all they have and that's all they use. That's all rheumatology does. So often we will use methotrexate in our first line, and we can sort of use that as a way of assessing how patients are treated and how effectively they're treated. Since if we were to choose two medications, hydroxychloroquine is for mild disease, methotrexate is for moderate to severe disease, other than corticosteroids. Now, steroids are often not without side effects. They often have a lot of side effects. And what happens is that a lot of primary care physicians will add the corticosteroids like the oral prednisone or the Medrol dose pack in in sort of the waiting period until they see a specialist. So when we're looking at primary care physicians, since almost universally all patients will be first evaluated by the PCP before they come in to subspecialty, this is an area where you can see the perceptions of care, and we can see the probability of not prescribing a DMARD even before their appointment. Now, these initial medications have been around for decades, and there's a lot of comfort, there's a lot of safety data that it is not disease, it's not specialty limited. In other words, anyone can prescribe it. It's not limited to rheumatologists. Therefore, if a primary care physician prescribed methotrexate, it would be filled just like it would be from a rheumatologist. And these are the perceptions of primary care physicians of reasons why they wouldn't. The highlighting I want to say is at the very bottom, we can say lack of sufficient or any knowledge. And this was a significant percent. The univariate odds ratio here was the highest 9 from any one of them. And here you can see the factors of referring to rheumatologists influencing. And one, they feel uncomfortable prescribing them. And secondly, they think appointments are hard to get. And both of these factors are sort of in the culture of things. We all sort of assume subspecialty referrals are getting harder to get, and rheumatologists are getting less and less in number and farther apart. But is that really true? So, and how are we in Delaware in that? So, where is the perceptions of primary cares? Are we the same? And is it true that patients are having disparities of access given the large sort of spectrum of cost and different options that are available? So, our aims of the pilot, basically, number one is to assess regionally in Delaware, using Delaware Health Information Network, where we are as a prescription sort of as a whole. Where are we in our spectrum of prescriptions, ranging from the steroids, which we hope are not used at all the way to the injectables and infusions, and how equitably, I guess, and are there disparities in certain groups or subgroups that are getting one type of treatment versus the other? Second is to determine if that prescription pattern is related in some way to the patient's education, their employment status, disability, housing. Geographic is a very big one in Delaware. And lastly, how are these perceptions sort of playing a role in the management of these patients? So our hypothesis is basically disparities exist, that there's probably a difference in the care of a Spanish-speaking uninsured person as opposed to someone who's been I don't know what you want to call the elite, if you will, but there's a disparity in how these patients may be treated. And a first step, and the pilot is to first identify them, and then second, see how they're perceived, and third, what other factors play a role. So there's two approaches to the pilot. This is all proposals. So quantitatively, this is where DIN comes into play, and that gives us broad data beyond Christiana care to a lot of specifics. So we can exactly see the prescription trends. Any prescription that was sent to a pharmacy from any provider, regardless of primary care, rheumatologist, or even urgent care, you can see which medications were prescribed from the beginning. We can also see the blood tests, the initial RF and CCP in the beginning. We can see when the first test was ordered, and we can use that as our starting point to evaluate the time to treatment of the diagnosis to the first line treatment. And second, it gives us a lot of in-depth data about the patient's background, geographics, et cetera. So coming back to this dual positive, and I put this here because the purpose of the study, it's hard to objectively measure if primary cares will be able to standardize joint swelling and stiffness, but it is very objective to have blood tests. So if you have both of these blood tests positive, it's almost saying it's rheumatoid arthritis and not something else. So that should be convincing enough to even a primary care provider, that if both are positive, that maybe this patient should be treated if they're active. So this was a pilot, a mini one sort of done within Christiana Care, just to a proof of, just to submit the LOI and get a sense of where are there even changes. So this is of only the methotrexate. This is a very, very specific of only patients who are rheumatoid factor and CCP positive. The pilot will actually involve more of either or, but just for this purpose, we chose the very specific of both positive. So we know there's no non-rheumatoid arthritis patients. And we can see this is only looking at one subset of it, and we're only looking at methotrexate, the first line, and we're looking at male and females. And already we can see that, I don't know if this is a bias, but it seems like there's a signal where for some reason females are taking longer to be started on treatment than their male counterparts. Why that is, I mean, I can speculate. There's more data would be needed, but I can speculate is because females have, pain syndromes can be sometimes misclassified when you have similar symptoms, but for some reason you call them fibromyalgia or, excuse me, a lot of these second things but in fact they are inflammatory. And we can see for both the median time to treatment for females is almost 3 months versus for 4 months, and for males is about 3 months. For reference point, the American College of Rheumatology recommends 3 months or less at least of treatment, ideally sooner the better, to prevent disability. The complications of untreated rheumatoid arthritis are, of course, there's damage to the actual joint itself. And the longer you wait, especially if it's active, the greater the probability of that occurring. This is the second of the same methotrexate only of both dual positives stratified by race. And we can see that there is a very wide, and there's a little bit of change. I'm not, whites and blacks here are both similar, but the timings are very long. The median time is still 4 months. Interestingly enough, Asians are some reason lower. They're being started on treatment sooner. And that perhaps maybe, I can speculate that they may have more severe disease, therefore they're more urgently looked into when first line methotrexate is started. But this is only the methotrexate. I imagine once you open this up to the breadth of the treatment options, if they've been on other things first, and these are all new incidences. So there is clearly differences between groups. There's differences even between genders and races, perhaps, as that may be playing more of a role. And we haven't gotten into the geographic area yet. And that level of data is hard to get from just Christiana Care by itself. So this is where the pilot comes into play. The qualitative part is the perception part. So this is going beyond the data and to get sort of the grassroots level. What are the perceived barriers, if disparities exist, on the quantitative analysis? The second part is, what are the barriers relating to it? And then this is where we have the interviews, the one-on-ones, the snowball sampling method to sort of get these patients who have a hard time accessing medical care. And these will be structured, semi-structured. So our hope is to, identify the barriers and then to the community perceptions, the primary care prevention perceptions, especially related to disparities. And I want to highlight healthcare literacy, especially when you're trying to access some of these specialty drugs. It's not always so clear communicated about how to take them, what the best way. There can be anywhere from once a day, once a week, once a month, some are even every 2 to 3 months. The impact essentially is to be able to, one, be aware of the disparities and be self-educated. Secondly, this is where it would lead to a future work on advocating for education, in terms of educating both the patients about identifying and advocating for themselves, and also for primary care providers or taking the initial lead on if you do have and for I can just mention Christianic care and a lot of specialties, rheumatologists in the area, the wait is anywhere from 2 to 3 months to 1 year, depending on where you are. Um, this is very heterogeneous, and you wouldn't want a patient who, especially is dual positive, to wait 6 to 12 months just being treated with corticosteroids and cumulative dose increasing the potential for complications, disability, and side effects that otherwise could have been prevented by just simply early treatment, which now is fairly standardized. So we're hoping to have the long-term benefits. This is going to be a community sort of effort, and we're hoping to get this sort of first off the ground and see if there is how much work needs to be done and further investigate.